Our next topic is improving clinician well-being and resilience and addressing recruitment and retention challenges by Tony Back. And Tony is professor of medicine at the University of Washington. There he co-directs the palliative care program, but I don't think that really describes what Tony does both locally and nationally, where not only is he worried about how to provide the best in palliative care and supportive care for our patients, but he's turned that lens around and thought about how we do our work and how we take care of each other as well. So, in that way, Tony, you've clearly been an inspiration to many of us, and thank you for being here.
Thank you so much. It's a pleasure to be here. I got into this whole resilience issue, honestly, as a matter of personal survival. As a young oncologist, I followed these really famous oncologists around and thought, wow, this is how this really works. And, in my own kind of journey, which is what pushed me from just thinking about it for myself to thinking about it for others, was like this. This was a viral thing for residents a couple of years ago. I don't know if you guys saw it, how being a doctor became the most miserable profession. And, you could chalk this up to, hyperbole in the popular media. But, the reality is that burnout rates are climbing. There's very clear data that the incidence of burnout is increasing. I know the National Academy has done quite a bit of work on burnout already about this issue, so I'm not going to repeat that data. There is a growing clinician backlash about being assigned dealing with their burnout as something more to do, right? And I think there's this widespread sense of hopelessness and powerlessness. And so, what should we be recommending at the policy level here? I am going to choose a few selected pieces of literature to talk about, and I'm going to make some very specific policy suggestions for you to think about and discuss. But I'd wanted to start with and go back to the situation on oncology. We were hearing a little earlier about how the number of oncologists, people entering oncology is decreasing. The old people like me are getting older. We're going to retire. And so Dr. Cox, who you were going to hear from later, invited me to write a commentary on this paper in the Journal of Oncology Practice. Inpatient hematology oncology rotation is associated with a decreased interest in pursuing an oncology career among internal medicine residents. Okay, ready? This is our engagement/recruitment funnel, right? This is what's happening right now. So what this study was, this was a single institution study, 96 medicine residents at a well-regarded Northeastern medical school with a large cancer center who did a 2 to 4 week inpatient hem-onc rotation, right? They did pre and post measurements. This is basically the entire class of internal medicine residents. And if you look at this, before and after, their empathy, which was not that high to begin with, self-report, right, went down statistically, right? Their PTSD symptoms, which were high at the beginning, did not change. And then their career interest in oncology dropped. And you know what, if you want to look at what the numbers are, okay, this was a 0 to 5 scale where 0 is I'm not at all interested, like get me out of here, and 5 is I'm interested almost all the time. They started at 1.43 and then dropped to 1.24. Like, we have an engagement problem here, right? What is going on here? So I wrote this commentary with this third-year resident. Okay, she kind of laughed and shrugged and said, well, we're just order monkeys. And I said, this is like, this is when I'm beginning to realize I'm out of touch. I said, what's an order monkey? And she said, well, people tell us to write things and we enter them in the computer. Like, a monkey could do this. The other term is scut monkey, in case you haven't heard that. But basically, her point was they are kind of the very end of this long, instrumental, procedural view of medicine where there is this attending oncologist who is not even physically in the same building, who is telling the team what to do, and the inpatient oncologist, who is the attending, is kind of going, okay, well, whatever they say. And they don't feel good about it because the patients on these inpatient services are the sickest patients who are having the most horrible complications, who have the most complicated family situations that the inpatient situation couldn't do. So if you look at this, I mean, I know this is a single institution study, but I have to admit, my institution, across the country, different coasts, different everything, it's really the same. And I hear the same thing everywhere. This is a tip of the iceberg of what we are dealing with, the culture of working in oncology now, right? That is why things are dropping. If you look now to step back, so that's this big situation. If you step back and look at, how should we think about dealing with burnout and proactively building resilience for cancer clinicians? I'm going to make the case, and this is very simplified compared to what the National Academy put out as a conceptual frame. I really think about it as a set of physician skills and a set of workplace factors. And these are well documented in different literature, but we pulled together all the literature where there was some empirical evidence for something to create this list of what to pay attention to. So if you look at the individual kinds of level issues, there are things about managing energy, which actually is a skill, using your attention mindfully, finding healthy boundaries, reframing cognitive distortions. This is the oncology fellow says, actually, this is all my fault, right? Or the attending oncologist who says, I should have just done one more regimen, right? Regulating their own emotions and discovering meaning daily, right? Without some individual skills, you will not do well even in the best system, right? But conversely, if you're in a terrible system, you can have great skills and you will still have a very hard time. And the system level skills, and these are empirically derived from multiple studies of many kinds of organizations that involve human capital, right? That you need to optimize the workload, you need to enhance efficiency, you need to enable people to be autonomous, these are professionals, you need to allow people to integrate their work and home life, you need to uphold their values, and values alignment, it turns out, is really critical. I'll say more about that later. And you need to create community, right? Here's what I heard. This is it. I was across the street over here in Alexandria at an ASCO thing for fellowship directors, and one of them said to me, they would like somebody else to fix this. That's right. That's kind of the instrumental view of the anti-leadership qualities that Dr. Carlson was talking about. Leadership is a big deal here. Tate Shanafelt, who's a mentee of mine, did this nice study at the Mayo Clinic about the impact of organizational leadership on physician burnout and satisfaction. So what this showed is that leadership has a powerful effect. They surveyed almost 4,000 physicians with a 72% response rate. Supervisor leadership scores of the unit that you're in. So everybody just evaluated the next person up. They correlated very clearly with burnout, right? P less than 0.001. What's also really interesting for you pharmacology geeks out there, there is a dose response to this effect, right? This was a 50-point leadership score that people rated their superiors on. For every 1 point increase in the leadership score, the burnout rate of that unit went down 3.3%, right? Very statistically significant. So leadership, as Dr. Carlson is talking about, really matters, and it's a different kind of leadership than I think many of us grew up with. This is the leadership that elicits responses, solutions, problem solving from the ground up, right? And I think this is something we need to really pay attention to. Here's my next thing. Okay, I was at the Coalition to Transform Advanced Care. This guy who's a physician CEO gets up and says, my favorite day at work is when Epic goes down. I'm like, okay. I went to shake his hand. He's speaking for all of us. Okay, this EHR issue is a huge issue because this guy's up there saying, then when Epic goes down, I can just sit and talk to my patients. I can just do my real work, right? This is not just hyperbole. Right? There is a relationship between the clerical burden of the work that you all do as cancer clinicians and basically, the EHR. So again, this is another thing from Tate, 6,000 physicians, this is a variety of specialties, not just oncology, 84% of them used an EHR, and the ones who used the EHR had a very significantly lower satisfaction with the amount of time they spent on clerical tasks, i.e. they spent a lot more time. And those who were doing computerized order entry had a higher risk of burnout, right? So something is happening in the interaction between clinicians and these electronic health records. And I can tell you what it is. Here's an illustration. I did a little consulting for a group in California about, this was an oncology group in California, about their burnout and resilience. And I met a radiation oncologist who basically tries to do see his patients and do the interactional stuff while he's at work. He leaves all his documentation to the end of the day so that he can go and have dinner with his kids on time, right? So he goes home to have dinner, and he has his computer workstation set up in the living room, and he works for 2 to 3 hours every evening, and that's the only way he can participate in family life, if he sits there with his computer and does his documentation. And the administrative leader of that system said to me, like, I am worried about him. And the guy himself said to me, I don't know how much longer I can do this. Like, who could do this? It's absurd. So this is something I think we need to do something very specifically about. Okay, ready. Last big piece. This was an oncologist who had a life-threatening cancer. I don't mean like a little melanoma, not like a little melanoma that got shaved off, something bad. What he came back and then had this horrible case of burnout. And he said to me, like, realizing I was burned out was harder than having cancer. Like, that is saying something, right? This is somebody who knows the territory and knows what they're dealing with. And I think it speaks to what we are dealing with about how we talk about and treat occupational stress and burnout in our culture, right? This is one of our peers. It's interesting that, if you ask doctors how well calibrated they are about their own kind of risk of burnout, it's not good. Like, when these investigators gave surgeons, and these are not cancer surgeons, this is all surgeons, right? They gave them the opportunity to take a little quiz on a private portal and give them their risk of burnout and compare to what they thought. They were totally inaccurate, right? One thing is they didn't realize how close to burnout they were, because we've all been trained to ignore all these things, right? And then they gave them a personal intervention to promote behavioral change. And so these things are possible, right? This other thing, you've probably seen this, an educational program in basically this was a mindfulness kind of intervention that had a very strong effect in decreasing burnout among primary care physicians. This is, again, a single institution study, but clearly 70 physicians, pre and post, they did this combination of mindfulness, self-awareness, and community building. Their burnout scores declined. EE is emotional exhaustion, declined very dramatically at 12 months. Their empathy scores increased. Their total mood disturbance declined. So there are things that actually are possible, but what you have to do is get physicians into a place where they're really ready to try some of this stuff. There's a really interesting white paper just recently by the Massachusetts Medical Society and Harvard Global Health Institute about what to do. And I thought these were good recommendations to build on. And here they are. 1 is proactive mental health treatment. 2 is different EHR standards, especially about usability and open APIs. 3 is chief wellness officers at every major medical system. And I'd like to take some of these things a step further. So here are my suggestions for policies that would improve the work lives of cancer clinicians. Number 1, new certification requirements for electronic health records. We should have decision-critical information that is no more than 1 click away. When I go to sit down and look at the health record about somebody I'm assessing for a new cycle of chemotherapy, I don't want to look at care. I don't want to look everywhere. Care everywhere doesn't mean I should have to look everywhere. I'm doing care here, right? There should be complete interoperability for key treatment goals so that when 30% of the people in my medical system, they end up dying in a different system, right? There should be complete interoperability for the key decision goals that patient is pursuing. And I think we should have ASCO and AMIA, the American Medical Informatics Association. We should have them define what decision critical situations and key goals are, and we should ask CMS to say these are requirements for certification. And if we don't get them, they're going to be, large fines. Think European Union and Google. Okay, number 2, new publicly reported institutional measurements. I think it would be interesting for the public to know how much clinician time is spent on clerical activity. How much time do doctors spend entering data produced from one part of the electronic medical record into another electronic part of the medical record because it's not sucked in automatically. I think it'd be interesting to know what the level of clinician turnover is. I mean, everybody says to me, these institutional leaders say to me, wow, it's expensive to do this wellness stuff. And I'm saying, do you realize how expensive it is for your institution when one of your key clinicians leaves, right? That is something that costs a doctor or a nurse who leaves. That probably costs your institution at least a couple $100,000, right? We heard that, you can't get a nurse up to speed in 6 weeks. Then the last thing is clinician ratings of leadership commitment to well-being, right? Publicly reporting these metrics would actually put some feet to the fire for all these issues. And I have more. Number 3, and this is building on what Dr. Carlson said, there should be real incentives and rewards for collaboration and teamwork that are built into the work of oncologists. Like my own incentives are purely individual. There is no formal institutional incentive that actually encourages me to work with my team. It is all time that comes for my time. Like there's nothing reinforced about it. I would actually point to the measure of psychological safety. Amy Edmondson at Harvard Business School has done a lot of interesting work about the importance of psychological safety in teams. And Google, probably you realize in Project Aristotle identified psychological safety as the single most important component of high-performance teams, right? It is not enough, Google has learned, to just throw a bunch of smart people in a room, and we should learn the same lesson, right? The other thing would be about measuring patient and family perceptions of teamwork. How well does the team work together? How fragmented is the team? I think those would be very straightforward, simple measurements. And if you ask patients and families, they're pretty clear about which teams work well and which don't. They can see it, right? The 4th thing, and I'm leaving this individual stuff to the end, is creating opportunities for clinician renewal that are built in. Built into the workplace or workday or work something. So it is not clinicians. It is not the responsibility of clinicians to do this on their own after they've been at work all day and then done their documentation for 2 to 3 hours at night, right? We could offer these individual online well-being self-assessments, like ASCO could do that. I'd be interested in that. You could have national benchmarks, international benchmarks. You could normalize professional development as something that happens on work time, and we as cancer centers ought to be investing in the leadership capacity and professional development of our workforce if we want them not to retire early, which is what is happening now. And then finally, I don't know that there is enough data out there that I can recommend one single thing about programs to. There's not one program about building clinician resilience, but there are clearly a bunch of programs where there is some data about something that works, and we should be making these programs easily available, and there needs to be encouragement to get these programs scaled everywhere, because I think different people enter this space of how do you build your own resilience in a very personal way, and I think we need to build a kind of marketplace of resilience building things that you do. One of the interesting commentators that I said, just to step back, these were all really short-term policy things, right? And yet, I feel like these are all nibbling at the edges of this bigger issue, which is what one commentator said was how automated and transactional medicine has become. And I think for those of you who do cancer care in a daily way, and in many ways, cancer care is an amazing career, right? I mean, the relational, teamwork, connectional parts of our work, they are some of the most important parts of our work that you do. I know that there's this whole thing about, we had a discussion about, how far you have to drive for radiation oncology, radiation machine. I mean, if you don't have enough of a relationship to convince your patient that radiation is worthwhile, they will look on Google, read that alternative medicine stuff, and go do that, right? Like, we're not the only information purveyor in town anymore. And so I think the experience that we provide patients that builds trust for them and leads them to believe us as really having the evidence-based treatments that are out there, I think that's really important. You know, we'd all love a moment like this. Like, this is possible for us. And you have all had these moments, and yet they are becoming more in danger in our current environment. So thank you very much.